So with that, good afternoon and welcome to our IASP and Pain Research Forum webinar. I'm Greg Carbonetti, the Senior Manager of the Pain Research Forum, and today we're excited to bring you a webinar produced by IASP's Methodology, Evidence Synthesis, and Implementation Special Interest Group titled Quality, Bias, and Integrity in Pain Research, Creating the Next Generation of Pain Science. Today we'll be hearing presentations from Dr. Andrew Moore from the University of Oxford in the UK, Dr. Emma Fisher from the University of Bath in the UK, Michael Ferraro from the Center for Pain Impact at NURA in Australia, Dr. Neil O'Connell from Brunel University in the UK, and Dr. Sebastian Straub from the University of Alberta, Canada. Excuse me. Additionally, you'll be meeting Dr. Amanda Williams from University College London in the UK, who will help us to facilitate our Q&A session after today's presentations. The IASP and PRF are thankful for everyone who could join us today and remind you that today's webinar will be recorded and available for later viewing at IASP's Pain Education Resource Center. I'd also encourage our viewers to utilize Zoom's Q&A feature to ask any questions you may have during today's proceedings. Furthermore, I'll distribute a link in the chat near the conclusion of today's webinar, which will provide you all an opportunity to evaluate our work. At this time, I'd like to introduce Dr. Neil O'Connell, who will help to moderate some of today's proceedings and give an opening remark. Dr. O'Connell is a reader at Brunel University and divides his time between research and teaching, and previously worked as a musculoskeletal physiotherapist. Neil had been the coordinating editor of Cochrane's Pain, Palliative, and Supportive Care Group, and was a member of the Guideline Development Group for the UK's National Institute of Health and Care Excellence, or NICE, and the Guideline for the Management of Low Back Pain and Sciatica. He also contributed to the NICE quality standard on that topic. With that, I'd like to pass today's proceedings over to Neil and look forward to hearing from our presenters. Thank you so much, Neil.
Thanks, Greg. Thanks for that lovely introduction, and welcome everyone. It's a delight to be able to welcome you all to the first webinar for our special interest group since we had a new committee structure. So I'm happy to be able to introduce myself as the new chair of MESISIG, and also to introduce Dr. Emma Fisher, who's our vice chair now, and Michael Ferraro, who's our secretary treasurer. I'll be introducing those separately before those talks, so I'll give you more detail then. So today's theme is about quality, bias, and integrity in our research. And all of those themes speak to the same challenge in pain research. That is, to create evidence that we can bring to bear to help people with pain, but evidence that we can confidently place our trust in. So in the webinar today, we're going to hear from speakers on a range of topics that touch on some of the things that might increase the trustworthiness of our evidence, but also some of the things that threaten it. And hopefully we'll consider some ways forward to improve our situation. I'm delighted that we've got some excellent speakers with a wealth of experience in the evidence space. We've got a very busy program, so we won't be taking questions at the end of each talk, but there will be time at the end for a discussion and for us to take your questions and your thoughts on the topic, which will be facilitated by Professor Amanda Williams. So please do come ready, put your questions in the chat, do come ready to participate and get involved. We'd love to have a robust discussion at the end. Before I introduce our first speaker, just to also put a little pitch in for MESISIG, if you're interested in evidence, methods, evidence synthesis and implementation, we would love to have you on board with our special interest group, and we hope to have a very vibrant program for our members going forward. So I'm going to introduce our first speaker now. He doesn't need a great deal of introduction. Many of you will be familiar with Professor Andrew Moore. Andrew studied at Balliol College in Oxford as a biochemist. He's worked in the NHS, in industry and in academia. He was the founding editor of the evidence-based medicine bulletin Bandolier and has worked in pain research for over 40 years, working with the Cochrane Pain, Palliative and Supportive Care Group in an editorial capacity since it was founded. Andrew's main research interests involve methods of systematic review, meta-analysis in clinical trials, and how to represent the results of clinical research for best use in clinical practice. He's the author of several books on pain and evidence-based medicine, over 700 scientific papers, and over 100 Cochrane reviews. He was unable to be with us live today, but we're delighted that he's recorded his talk for us. So Greg, if I can hand over to Andrew now, and we can play that presentation.
Well, hello, everybody. It's good to be joining you. And I'm going to be talking very, very fast because I've got 10 minutes to talk to you about quality and bias in clinical pain research. I'm just going to touch the high points. I'm sure that the slides will be available for you so you can pick up references from there. The key word is trustworthiness here. The business about evidence in pain is not new. People have been doing it for decades and decades. This is one of the very first references to Henry Beecher telling the world that everything they thought they knew about pain in 1946 was wrong. And a whole host of other people, some of whom are on this slide, worked long and hard to try and find ways of doing pain trials that told the truth reliably. And it was jolly hard. And subsequently in IASP, and particularly in the systematic review SIG and evidence SIG, those concepts have been checked time and time again for validity, and they've come up pretty well. Having said all that, the one thing that is true is that over the last 3 or 4 decades, we've learned that there are all sorts of other problems out there that we need to think about. These are size, issues around risk of bias, issues around imputation methods, most importantly, perhaps outcomes, and then the unhelpful area of fraud and fabrication. So Richard Horton, talking in the Lancet some years ago, said that much of the scientific literature, perhaps half, may simply be untrue. And then he gave a whole lot of reasons for it, amongst them being small sample sizes. What do we mean by small? Well, here take an example from 8 Cochrane reviews of perioperative interventions for postoperative pain, with just under 300 groups in it, treatment groups. And you can see that for most of them, 94%, there were fewer than 50 patients, and most of those were fewer than 30. Now, that's pretty small. And the problem with that is twofold. First, it's to do with randomness. So in the left-hand pane, you can see who trials on ibuprofen compared with paracetamol, same dose, same drug, same measurements, same outcome, same duration, and yet the results are all over the place. Why? Well, if you take those data and run them in a computer in various simulations, what you find is that just by the random play of chance, you get essentially the same result. So you can get any answer you like by using small trials. There's another problem, a secondary problem, and that is that small trials show more beneficial results. And this has been shown widely throughout the evidence area, particularly in pain, with this beautiful example on treatments of osteoarthritis in the British Medical Journal some years ago. The second issue is the profound tendency of people to see what they want to see, which is what we call bias, and there's a lot of it about. And we see this now because we formally perform risk of bias estimations when we're doing systematic reviews. And we call it low risk of bias, which means we give it a green light, or we call it an unclear risk of bias when we give it an amber light, or if it's a high risk of bias, we give it a red. And this is a typical example here. And what you see is lots of red dots, masses of yellow dots, a few green dots, and not one of these trials is green across the board, which is what we really want to see. And that's only part of the problem. Wherever one goes, one sees that high risk of bias is a common thing in trials that we put into systematic reviews. Here's an example, or several examples actually. One is in blue from 1640 trials in 96 Cochrane reviews, some other trials in fibromyalgia from Cochrane reviews again, and 130 RCTs in a single Cochrane review of IV ketamine. You can see the answer, that in all of them, high risk of bias is common. In few of them is low risk of bias right across the board. So there's a great deal of uncertainty as to what we're putting into systematic reviews. Another problem, which has been argued about in pain for many decades, is the issue of what we do about when people drop out of trials. How do we impute an answer that we might be able to use? People have said that, actually the problem might well be is when you get to the end of, say, a 3-month trial, only a small number of patients are still in the trial, and most of them, or the data that we use, is largely hypothetical. Here's an example for tapentadol, oxycodone, and placebo in a 3-month trial. And the top line there is oxycodone. 40% of people have dropped out at 3 weeks, and 60 to 70% of people have withdrawn by the end of the 3-month trial. The result of this is profound. Using last observation carried forward, which is what statisticians want us to do, you get this result that both tapentadol in blue and oxycodone in red are analgesics. They are better than placebo. When you use a more conservative baseline observation carried forward approach, which is what we used to do several decades ago in pain, what you find is that tapentadol is still an analgesic, but oxycodone is actually significantly worse than placebo. Julius Caesar said this, and it's an interesting way of thinking about pain. None of us really want pain, but pain is a complicated area. Here's an example of the difference between patients and their doctors in looking at pain. These are patients with rheumatoid arthritis in Vienna, and the rheumatologists were asked, what's the most important thing? And they said it's swollen joint counts. And the patients were asked what was the most important thing, and they said pain. You can see there's no agreement between them at all. If you think you know what somebody else's pain is like, you're almost certain to be wrong. And Tim Sears and Sheena Derry did this large comprehensive review published in Pain a little while ago now, showing that not only can professionals not estimate patients' pain, they underestimate it, and the extent of estimation is really very large indeed. Pain's important in all sorts of different ways. We know that if people who have pain have got poor quality of life, you see that on the left-hand panel here. Darker the blue, more severe the pain. Lo and behold, quality of life drains away. But it's also important for quantity of life. You see on the right-hand panel there in blue, those people with osteoarthritis of the hip and knee with disability are much more likely to die over a 15-year period. And there are various other examples which show that as well. What people want, if you ask them, and these references, amongst other things, show a systematic review on this right across the board, whatever the pain, they say they want their pain gone, and they want it gone now, please. And treatment success is 50% to 70% pain reduction. If you have that pain reduction, lo and behold, quality of life increases. So on the left-hand panel there, we're seeing the percentage pain relief of a baseline. You see that stepwise increase as pain relief improves. On the right-hand panel, what we're looking at the pain state at the end of a trial. So less than 30 millimeters is no worse than mild pain. In the middle, you're looking at moderate pain. In the top, on the right-hand side, you're looking at severe pain. And you can see again that those with mild pain have a large quality of life benefit. But of course, there's no average. It's still one of the most important lessons. In pain trials, people either tend to get very good pain relief or very poor pain relief. And that's true right across wherever you look, in postoperative pain or osteoarthritis, low back pain, painful diabetic neuropathy, migraine, normal head tension, headache, it's exactly the same. When we look at average results, we're looking at the result that fewest proportion of people are likely to have, which means we've got to give results in sensible ways that are useful to patients and their carers. Another simple example of postoperative opioid requirement, for example, in about 1,000 patients. And I'd be very hard pressed to describe that as a normal distribution. The last thing to say is that we've unfortunately come to learn that our literature is polluted. It's polluted by people who think they're so clever that they can make up data and get away with it. And increasingly they can't, although they have done for some time. This guy is called Yoshitaka Fuji. This data are taken from Retraction Watch. This man has had 183 clinical trials retracted, basically because he made up the data. And those bars in red there are all people who are working in pain and anesthesia. One of the people who put the finger on Fuji was a guy called John Carlisle, who's an anesthetist working in Devon. And he is now an editor of Anesthesia. And some years ago, he started looking at the data that were reported to papers submitted to Anesthesia to see whether they made sense. There are various ways, and Neil, I'm sure, will be talking about this later, about ways in which you can tell. And he found a small proportion were suspect, that is, he thought they were false, or they were zombie, which means that they're so crazy that, there's no way you could possibly believe that they were true. And this disturbed him, though, and he started asking for the data rather than just the results as reported. And there was this enormous explosion in false and zombie trials. There's an awful lot of error out there. There's an awful lot of misrepresentation out there. And there's an awful lot of people actually fabricating data. Now, you've got to put all of these various things together to get evidence that you can trust. And don't just trust systematic reviews, because systematic reviews can be very poor indeed. This is an evaluation of 323 systematic reviews of pain outcomes in various overviews. And they look at AMSTAR, which is a generic measure of whether the results can be trusted or not, according to the methods. And you can see overwhelmingly, these are critically low or low in terms of the confidence they give you in their results. And only a few are moderate or high. And those are overwhelmingly Cochrane reviews. And those overwhelmingly Cochrane reviews, and I might also say systematic reviews that appear in Pain, for the most part, are because the people doing them are people working in the SIG, and because they know that they've got to put all of these various things together to get trustworthy evidence. So let me end by saying that we've really got to start following Doug Altman. He said to maximize the benefit to society, you need not just do research, but do it well. And we've got to start doing trials right from the beginning. And I'm going to end there and hand over to people who are going to expand your thinking in some of these areas. Thank you for listening.
Many thanks to Andrew for that thought-provoking talk. Just to follow up on that, not only to maximize the benefit to society and patients, but also to minimize potential harms as well. Let's introduce our next speaker. Our next speaker is Dr. Emma Fisher. We're delighted that she can come and speak for us today. Emma is a Versus Arthritis Career Development Senior Research Fellow at the University of Bath, and is has been an editor for many years for the Cochrane Pain, Palliative and Supportive Care Review Group. Her primary research interests focus on the risk factors for developing chronic pain after an acute musculoskeletal injury in children and adolescents. Dr. Fisher is interested in evidence-based medicine and quality. She's conducted a number of systematic reviews for Cochrane and more recently produced a guideline for the WHO's guideline on chronic pain management in children and adolescents. This work now includes understanding narrative bias in science and determining the trustworthiness of data in evidence-based medicine. Her other research interests include anxiety in children and adolescents with chronic pain, psychological treatment mechanisms and evaluation, goal pursuit when experiencing pain, and pain after surgery in young people. And Emma today is going to speak to us about research integrity and specifically on the issue of spin and diversion. So many thanks, Emma. Over to you.
All right, thank you, Neil. I'm assuming that everyone can hear me unless someone starts speaking. So here we go. Neil, thank you for the kind introduction. As Neil's just said, I'm going to be talking to you about spin and diversion in pain science. And this is an area that we became interested in probably about a decade ago. There we go. And the reason for this, as Neil said, we've done a number of systematic reviews over the last 10 years. In pain, my primary area is in pediatrics. So we've looked at the psychological literature, the pharmacological literature, and then most recently we've been looking at cannabis-based medicines and cannabinoids. And what we've often found along this journey is that we read a lot of abstracts, thousands and thousands of them, as we sift through to see what should be included in these systematic reviews. And what we find is that some abstracts seem very positive and we think it's going to be a great trial, and then we get to the results section where we're interrogating and trying to extract the data, and it doesn't quite match up with the enthusiasm that the abstract has shown. And I'm sure none of you are on this call, but there are people out there that only read scientific abstracts and take that as the word, and they then go on and they cite it and they talk about it without necessarily interrogating the results and the data within that article. And that can be very misleading, because as scientists, inherently, we are salespeople. We are trying to sell our publications to the best journal. We are trying to sell our ideas to the best funders, and we're trying to convert our research into policy. And so we have to sell it to people. We know that significant findings are most likely to be published compared to non-significant findings. And so I think that there has been an emphasis in the past that even if your primary outcome didn't come out as significant, then maybe you talk about your secondary outcome and pretend like your trial might have been focused around that area. Now, you might call me cynical, but having read thousands of RCTs, I have seen the switching of primary to secondary outcomes happen quite frequently, and I still see it now as a peer reviewer as well. So this is why we became interested in spin. So how does our interpretation of the abstract match onto the results in these publications? And looking over the scientific literature, it happens quite a lot, because we're not the first people to look at this area. And despite the best guidance, and there is a lot of guidance out there now, as I'm sure that you know, we've got Prisma, we've got Consort, we've got AMSTAR, we've got guidelines on how we should write our abstracts and present our work. The bias can range up to 67% of abstracts, where people are writing their results more favorably than perhaps what is actually in the abstract. And so we set out and we wanted to develop a tool to identify spin in these abstracts, and to not only have it be used in pain, but be able to apply it to different areas and make it useful for across science, not just within pain. Now, on this journey, we decided to test this tool out on 2 systematic reviews that we had recently authored at the time, on cannabis, cannabis-based medicines and cannabinoids. Andrew Moore and Chris Eccleston, who were co-authors on this, were also part of this task force set up by IASP. Now, to be clear, I don't think that spin is only found in this area. We chose these 2 reviews and to interrogate spin within these areas because A, it was a recent area that we had recently summarized. So we were familiar with the field. We had an up-to-date kind of cohort of studies that we could interrogate, and we had also noticed it within this field, and it seemed like cannabis and cannabis-based medicines were gonna cure everything from some of the abstracts that we read. And so we really wanted to interrogate it to see how our measure measured up against these trials, and to see what we could find. And just to give you a brief example, these 2 reviews, so the one that we published and did is on the left and is published within Pain, and then there's a review that was published in the same year by a group of authors published in the BMJ. And what you can see here is that despite using more or less the same body of evidence, we're coming to 2 very different outcomes, and we're narrating it very, very differently. So we found low and very low quality evidence. We found evidence that neither supported or refuted the claims of efficacy and safety, whereas the BMJ article found moderate to high certainty evidence and small or very small improvements in the range of symptoms to do in patients with chronic pain. So that kind of struck us at the time as being quite surprising, considering how closely these 2 reviews were published together with no major developments in the field between the publications. So here's the narrative bias, or the spin questions that we developed and tested. There are 6 questions and then 1 overall rating, which is put at the bottom. So we were interested in title overreach, so whether that title extended beyond the study of the study methods and findings. Switching, so whether the abstract failed to present the outcomes in the order that they appeared based on the study registration preferably, or the method. So were they trying to promote an outcome that was perhaps significant over a primary outcome that wasn't. Selective reporting, so only reporting perhaps the findings that were significant versus those that weren't. Promoting the null, so if something was not significant, were they talking about it as either marginal or promising? The rhetoric, so does the abstract conclude results in a single direction without acknowledging contestation, complexity or quality? There was a safety claim, so if evidence for no greater risk than 1 in 1,000, so we had to do some calculations there. So they were the 6 questions, and they were all answered either yes or no. And then overall, we made a judgment, having read the paper and the abstract, how much of a problem does this paper have with narrative bias? And we rated that on a scale of 0 to 3, with 0 being no problems and 3 being serious problems. So they're the questions that we used. We applied these to all of the randomized control trials and systematic reviews from those cannabis reviews. And we also extracted other data, and we also rated those RCTs and systematic reviews using other tools. So the first one was AmStar2, which is a quality of systematic review tool, and the other is Consort. So we applied that to the RCTs to make sure that the reporting standards were up to scratch. And then there's a PAPAS developed pain critical criteria. I'm not going to go into too much detail on what that is, but there are 8 questions that we think are critical to having a high quality pain randomized control trial or systematic review. If there is interest in that, I do have a slide on it at the end, so I can share that with you, or you can look it up in Andrew Moore's paper, which is the cannabis one in 2021. And then we applied our own narrative spin questions to that body of literature. And here's what we found. So in the first column, you can see that, well, the questions, the RCTs of which we judged 34, and then the systematic reviews of which we judged 65. And you can see that most of the issues that we found were for safety claims. So a lot of these RCTs and systematic reviews were claiming that cannabis or cannabis-based medicine, whatever they were testing or reviewing, were safe for people with pain. And we judged that as not safe based on their own data. It was also interesting that all the safety claims were always in favor of the product. None of them said that it wasn't safe when we would judge that it was safe. So that was quite interesting. And then for systematic reviews, the other number that really pops out in this table is promoting the null. So saying that something is promising when in fact there is no significant result for that analysis. And then for that overall spin score, where we judged abstracts from 0 to 3, 0 being no problems and 3 being serious problems, it's encouraging that most of what we found were no problems. There were no problems in terms of spin, but you can see that over 10% of both the RCTs and the systematic reviews had serious problems. So there is at least a significant body of literature out there that does seem to have some spin going on. So in terms of the bottom line, we also had a look at a number of other things across these studies, and we found no association between the narrative bias or the spin tool that we used and any other reporting factor, which included that pain critical item scores that Andrew developed, that 8 items that I spoke about earlier. There was no association between spin and reporting quality such as Consort or AmStar, whether the trial was or the systematic review was funded by industry or academic. The size of the trial, and Andrew's just highlighted the importance of size, risk of bias score, also covered by Andrew, use of defined primary outcomes, author origin, or the age of the studies, all of which were relatively recent. So there's no kind of other default method in which you can judge spin, which I think is really important. Spin seems to be independent from all of these other factors. And so when you are reading different abstracts to do with either randomized control trials, systematic review, and again, I don't think that it's just limited to cannabis-based research, but it's also experimental work, observational work, any science that you're reading. I think that it's really important that you can't take whatever the author has written in there as Bible, but you actually have to go to the results, you have to read the results, and you have to interrogate them yourselves, so that you can make your own judgment as to the quality of that research. So this review, this narrative bias or this spin tool is under review at Payne at the minute. We're hoping that it will be accepted very soon. We've already done a number of revisions. So we're hoping that it will come out very soon and that you can interrogate it yourself. You can assess our own abstract for spin and hopefully be able to use it in your work if that would be helpful. And I just want to say thank you. Andrew Moore actually led this paper, so thank you to him for leading us on this expedition, to the other co-authors, of which Sebastian's on this call as well, so thank you to you. And then thank you to the authors of the IASP Cannabis Presidential Task Force, because they were obviously involved in collecting and interrogating that first group of trials and systematic reviews. So I hope that that's at least piqued your interest, and that you'll be a little bit more critical, and hopefully we'll be able to promote that paper once it's been published through Twitter and through the MESISIG. So thank you for listening, and I will hand back to Neil.
Thank you so much, Emma. It was an excellent talk, and I just couldn't agree more about that need for us all to go beyond the abstract and to make our own minds up from the methods and the data. And of course, if the information isn't there, that in itself should tell you buyer beware, perhaps. Now to introduce our next speaker, Michael Ferraro. Michael works at Neuroscience Research Australia. He's going to talk to research integrity from a different perspective, and that is around his exploration of retractions in the pain literature and patterns in there and what's driving them. Michael is a clinical researcher whose work is centered around the evaluation of treatments for chronic pain. He's also interested in prognosis research and evidence synthesis. For his doctoral studies, Michael is leading a multinational clinical trial testing 2 treatments for complex regional pain syndrome. Again, because of the time difference and Michael's in Sydney, he can't be with us live today, but he's recorded his presentation. And Greg, if I can ask you to start that now.
Thanks for attending today's webinar. Over the next 10 minutes or so, I aim to provide a brief overview of some recent work that we've done looking at retracted publications in the pain literature. Just before I begin, I'll mention that I have no conflicts of interest related to this work. So what is retraction? Retraction is a mechanism for correcting the scientific literature and for alerting readers when articles contained either flawed or erroneous data. And such data might arise from honest error, naive mistakes, or even fraud or other intentional research misconduct. Both the Committee on Publication Ethics and the International Committee of Medical Journal Editors have issued guidelines for retracting publications and to provide guidance on the form that retraction notices should take. And it's just important to keep in mind that the main purpose of retraction is to correct the literature rather than punish authors. Now we know that retractions in the biomedical literature are on the rise. These figures from Gaudino and colleagues published in JAMA Internal Medicine in 2021 show a clear increase in the rate of retractions and also retractions due to misconduct. And these are thought to be due to increases in total publications, but also changes to author behaviour and institutional policy. And for both figures, we can see that there's a bit of a drop in retraction rates over recent years, but this is likely to be explained by the lag between the publication of an article and its subsequent retraction. So why should we care about retractions? Well, retraction of medical publications can have direct implications for patient care and patient outcomes. We have several examples where erroneous or fabricated data have affected the results and conclusions of meta-analyses, and it's possible that the inclusion of such data has even led to patient death. We also know that unreliable studies, even after they're retracted, make their way into clinical guidelines, and these often go uncorrected. Investigations looking at the characteristics of retractions have been conducted across several fields, and they've demonstrated that factors like reason for retraction, the time between publication and retraction, and the host country of authors vary across disciplines. For example, we know that for anesthesiology specifically, the rate of retraction for misconduct is around 15% higher than for the wider biomedical literature. So we wanted to investigate whether the pain field is vulnerable to field-specific phenomena that drive retractions. To find retracted pain articles, we first searched the Retraction Watch database, which is a publicly available database of retractions. This database tracks and aggregates retracted articles through a range of sources that include publisher websites, user submissions, and social media. We also searched other bibliographic databases. We found 389 pain articles published between 1993 and 2022 and retracted between 1996 and 2022. As you can see from the figure, we found a significant upward trend in the number of retractions over time, with large spikes in 2009 and 2020. Now, we know that the 2009 spike is mostly explained by a mass retraction of articles published by Scott Rubin, who was an American anesthesiologist that was convicted and jailed for healthcare fraud. The reasons for the spike in 2020 are less clear. If we look a bit more closely at the types of retracted articles, some interesting trends emerge. While there were almost even contributions across study types, so clinical observational, clinical randomized and preclinical, the clinical studies were clearly dominated by pain research conducted in the peri and post-operative setting. And interestingly, preclinical studies were concentrated in different areas, mainly in osteoarthritis and rheumatoid arthritis, which came as quite a surprise to us. If we look more closely at the study design, we see another interesting pattern emerge. Here we present only the 5 most retracted author host countries. So we have China as the clear frontrunner, followed by Japan, the United States, South Korea, and then Germany. And we can see that of all included Chinese studies, more than half were preclinical, shown here in purple. Many of these studies were conducted in osteo and rheumatoid arthritis, as I mentioned previously. And the remaining countries mostly produce retracted clinical studies, which are highlighted here in colours other than purple. So is it surprising that so many of the retracted articles were conducted in anesthesiology? Well, not when we look at the list of authors who were involved in 3 or more retractions. So 7 of these 12 authors were practicing clinicians in the field of anesthesiology, and it's well known that a small number of authors contribute disproportionately to retractions. So in these cases, a single retraction was catalyst for wider investigations and then further retractions. And if we look a bit more broadly, we can see that 75% of all retracted articles had authors that were affiliated with clinical institutions, which were mostly hospitals rather than academic institutions. And this phenomenon has been observed in the wider literature as well. Looking at the reasons for retraction, we can see that the majority of articles were retracted for reasons relating to misconduct. Around 50% of all articles were retracted for data problems, which comprise data falsification, duplication, and plagiarism. Outside of misconduct, unreliable or erroneous data were the most common retraction reasons, comprising almost 20% of all retractions. But interestingly, we don't think that these data really tell the full story, and that's because we found many instances where retraction notices contained euphemisms for misconduct, which might suggest that there was either insufficient evidence to prove misconduct, or that journal editors were weary of publishing statements that are likely to attract legal challenge. So because of this, we believe that the actual misconduct rate may be higher. And again, looking at retraction reasons for the top 5 countries, we see that misconduct, which is indicated here in red, ranges from 61% of all articles from China to 92% of articles from Japan. And this again might be influenced by the fact that the Chinese studies had fewer prolific authors that were involved in a disproportionate number of retractions. We also wanted to look at how long it takes for an article to be retracted following its publication. As you can see from the figure, there was a significant downward trend in the time between publication and retraction. So there was an average time to retraction of around 5 years before 2010, and this fell to under 1 year more recently. And this probably represents improved practices of identifying and retracting untrustworthy articles. And the median time from publication to retraction was approximately 2 years. We found that this interval also varied by reason for retraction. So as we can see from the figure, data problems and ethical problems had the longest intervals, which are probably explained by the delays that are required to investigate and establish misconduct. And the other non-misconduct reasons all had median intervals of around a year or less. Finally, we explored the journal characteristics and article citations. The median impact factor was 3.8 for all articles, which is relatively low, but when we look at the ranking for each journal category, we can see that most retractions were in quartile 1 journals. So it might be that higher impact journals have greater resources to detect untrustworthy data, or maybe these journals are specifically targeted by individuals involved in misconduct due to the potential reward. It's quite difficult to measure the impact that retractions have on the scientific literature, so we just measured citations as a very crude proxy for impact, and we found that the majority of articles were cited less than 50 times, although a limitation is that we didn't assess whether these citations occurred before or after the retraction. And I'll just wrap up by providing a couple of final thoughts. So the main finding is that there's an increasing number of pain publications that are being retracted. The trends that we observe probably reflect growing number of pain publications, but also increased editorial and post-publication scrutiny, in addition to positive changes to journal policy. It's clear that journal editors and publishers don't currently have the means to systematically screen for untrustworthy data, but improved adherence to COPE and ICMJE guidelines for retractions should increase both the speed and the transparency of the retraction process. Lastly, we don't have robust methods to ensure that retractions are easily identifiable and don't go on to influence the scientific literature. But as authors, we can minimise the potential damage of retractions, starting simply by checking the retraction status of an article we include in studies, either by looking at the Retraction Watch database or by enabling automated retraction alerts in reference management software. Thanks so much for listening in today. I'd just like to thank my co-authors for their help and expertise on this study, and please contact me via email or on Twitter if you have any questions.
Thank you very much, Michael. Excellent work on the review of retractions. And we're really pleased to say that that's just been accepted for publication in Pain. So hopefully you'll be able to pick through the details very soon. Just allow me to share my screen, just 1 second. And let me just confirm, can everybody see my slides okay?
You're great,
Greg?
Neil.
That's great. Okay, brilliant. Well, thanks everyone. Moving on to my talk, I'm going to cover another aspect of research integrity, which is some of our recent experiences looking beyond bias to look at the trustworthiness of evidence from a kind of multifactorial integrity perspective. And it's going to take you on a story of some recent investigations we've done where we've worried that certain pieces of published research weren't necessarily meeting our standards for trustworthiness. In terms of declarations of interest, I have none beyond my employment at Brunel University and my past role as coordinating editor of Cochrane Papas. So when we talk about trustworthiness generally, you know, if we look at Google, it says the ability to be relied on as honest or truthful. And of course, if we think about our aspirations for the evidence that we bring to practice, that is what we would want. But I liked what Google's definition followed with as an example. They have to prove their trustworthiness to you. And that is that the burden of proof for trustworthiness should be with the person presenting information. Now, in systematic reviews, we review literature all the time for its trustworthiness, but through a very limited lens. We look at methodological rigor, i.e. through risk of bias or other quality assessments, depending on the study design. And we look at transparency, because obviously within that there are elements of how complete is the reporting of this study in order for us to be able to evaluate that risk of bias, that methodological rigor. But that's really only one piece of the puzzle. If we consider what it takes for us to really be able to trust a piece of research evidence, then we're going to want to know that there was really good standards of research governance, that there was that methodological rigor, that transparency around reporting, that the data are plausible and appear authentic and don't look suspicious, that the data are transparent and, as far as is possible, open and available to us to scrutinize, that researchers have taken steps to communicate their research in a balanced way. And I bring you back to Emma's excellent presentation on spin. And also that relevant voices and stakeholders have had a voice in the process of generating that research. And that in there, I'm really speaking to initiatives like patient and public involvement in research. So it goes beyond just looking at risk of bias. And, you know, risk of bias is an interesting tool and a useful tool, but it assumes that what's reported is reported in good faith and that the research has been done in good faith, or indeed done at all. And we need to consider, though, that there are plenty of examples, and Andrew has touched on some already today, where we know that research that makes it into the published literature has not been conducted in the way that it's been reported, or in good faith, and in some extreme examples has not been conducted at all. So we need to think of ways in which we can, I don't know why that slide's showing again, excuse me. We need to think of ways in which we might be able to evaluate that broader research integrity and trustworthiness of the research that is available to us. And this is quite a growth industry in the last few years. There've been a number of different tools developed for different purposes and different audiences. Examples include the reappraise checklist for journal editors, which is a checklist to try and look for risks to research integrity, publication integrity. Cochrane Pregnancy and Childbirth Group have developed a tool to evaluate the trustworthiness of clinical trials. And if they flag concerns on that, then they contact the authors. And if they're still not satisfied, they exclude those trials from their primary analyses. Stephanie Weibel recently produced another tool for looking for what they call problematic trials, trials where there might be serious concerns about integrity and trustworthiness. And so as Lisa Parker and their colleagues in Australia. And the one thing that these tools, all being a bit different, have in common is that they encourage checking to see if the paper that you've identified has been retracted or whether there are expressions of concern. Looking for markers of research governance, like pre-registration, like open science practice, like ethical approval. Looking to see if there are characteristics of the authors that raise concerns, characteristics around the methodology that raise concerns, and characteristics around the presented data that raise concerns. And having sort of set the scene now, I'm going to give you an example, and you can find this paper. It was published early in 2023 that I did with some of my colleagues at the Cochrane Pain Palliative and Supportive Care Group. And this all started when Amanda Williams and colleagues led the most recent version of the Cochrane Review of Psychological Therapies for the Treatment of Chronic Pain, a review that I'm sure many of you have read and been aware of. And I want to show you one of the key analyses in here, which is the evaluation, the meta-analysis of cognitive behavioral therapy versus active control. And what you can see here is a number of trials that stand out. And if you look to the left, you'll see that those trials share a common first author. Now, during the process of the review team contacted the author for clarification and to look for legitimate reasons why those trials might show such spectacular results. But they had some correspondence and weren't satisfied with the answers that they received. And here's another example of those results in the red blobs there compared to the rest of the body of literature at the time of that review. And it puts us in mind of this quote from Carl Sagan, that extraordinary claims require extraordinary evidence. And we felt that there was a need to look more closely at the body of work that these trials were drawn from. So we did a systematic search for trials from that lead author. We assessed risk of bias in the standard way using the Cochrane tool. We've performed a formal trustworthiness evaluation using the Cochrane Pregnancy and Childbirth Trustworthiness Screening tool. You can see it on the screen here. I won't dwell on it, but there are aspects of research governance, the plausibility and feasibility of the data, and any issues in the process or the results that might raise concerns. And we also looked across all the trials that we found from that author to see if there are any signs of duplicate data between what were purported to be independent studies or highly similar data. We found 10 trials in persistent spinal pain. They were all testing cognitive behavioral therapy, mostly CBT plus exercise/rehab versus exercise rehab alone. They all shared the same first author. They were all single center studies conducted between December 2007 and December 2015. In which in total 1,100 participants were randomized. And as you can see here, apart from blinding, which is a common issue in psychological trials, the risk of bias profiles are quite unremarkable. What we did find across many of those studies, 8 out of 10 of those studies, were these extreme results. Again, in the table above, you can see how the results of those studies in terms of standardized mean difference compared to the rest of the field. But if you look at this graph here, this is a bunch of effect sizes in blue from a range of pharmacological, surgical, and non-pharmacological interventions. And you can see where these trials from this group sit in terms of effect sizes. And I'm hoping you can see how divergent they are. And this is what we found. None of these trials had been pre-registered. There was no confirmation of ethical approval and no confirmation of adequate study conduct. And we contacted the ethics committee and they didn't respond to us. We contacted the authors with a list of potential queries. They chose not to share protocols or to share their data. We found that the baseline distribution in these RCTs was inconsistent with simple randomization, as reported in the studies, that actually in most cases, the baselines were more similar than we might expect to see if randomization had occurred. We found duplicate and highly similar data across independent studies, and that includes means and standard deviations to decimal places that were identical between a number of individual studies. We found erroneous p-values in the baseline tables. 8 out of 10 studies had extreme effect sizes. We could find no clear reason for that divergence, and there was low to no attrition in some studies, including one study of 90 patients followed for 2 years where no participants were lost from the study, which is very rare indeed. Okay, and again, I'm not sure why that slide has repeated itself. So just to summarize, we identified multiple concerns relating to research governance, plausibility, duplication of data, and they were not satisfactorily resolved through dialogue. And so we've asserted that these studies should be excluded from evidence synthesis and from clinical practice guidelines. And 3 of those trials have been retracted to date as we've raised our concerns with editors. We also formally logged the response of editors to our raise of concern. 8 trials with substantial concerns across 6 journals. 3 editors acted consistently with the COPE guidelines. That resulted in 3 retractions, 2 from the editors and 1 from the author team. And we've just been made aware of 1 further retraction that has occurred after an independent research group raised similar concerns to us using a different methodology. 1 editor has not taken any substantive action for 3 trials, and 1 editor expressed his confidence that the peer review process for those studies had been robust, and he alluded to academic intimidation in the sense that perhaps that's what we were engaged in. We have evaluated then the impact of these problematic trials on systematic reviews and clinical guidelines systematically. So I know I'm running up against time here. We found that these trials have been published, have been included in 32 systematic reviews and 10 clinical practice guidelines. None raised concerns around the trustworthiness of the data from those trials. 85% of meta-analyses in those reviews were highly impacted by the inclusion of those studies. Removal of those studies reduced effect size by 58%. And you can see on this graph here, effect sizes with and without those problematic trials. 9 out of 10 narrative syntheses drew positive conclusions. 9 out of 10 clinical practice guidelines made positive clinical recommendations for those interventions. But we don't have robust validated methods for looking at trustworthiness and integrity. There is a study going on at the moment funded by the NIHR, led by Jack Wilkinson from the University of Manchester, to develop tools for detecting problematic RCTs in systematic reviews. So much of what makes evidence trustworthy is frequently either just assumed or we take it as an act of faith. And that's actually a profoundly naive position. We don't know the scale of untrustworthy trials in the literature. There's a pressing need to routinely consider the trustworthiness of evidence, and there's quite a lot of work to be done methodologically to refine and validate tools for that purpose. And I'm really pleased to say we've just got a European Research Agency grant, a networking grant, to try and develop a kind of integrated architecture for trustworthy pain evidence. So watch this space. And one last comment from Richard Smith from the BMJ, and I include it here to be intentionally provocative, but in 2021, he commented that It may be time to move from assuming that research has been honestly conducted and reported to assuming it to be untrustworthy unless there is some evidence to the contrary. I want to acknowledge my co-authors, apologize for running slightly over there, and thank you very much for listening. Okay, I'll just stop sharing my screen. Okay, so just moving on to our next talk now. I'm delighted to be able to introduce Professor Sebastian Straub. Sebastian holds degrees in medicine and physiological sciences from the University of Oxford, where he also did his DPhil. After clinical work and research at the Oxford Radcliffe Hospitals, he joined the Institute of Occupational, Social and Environmental Medicine at the University Medical Center, Göttingen, Germany. There he completed his postdoctoral qualifications and his postgraduate medical training in occupational medicine and social medicine. He was an extraordinary professor at the University of Göttingen until he took up his post in the Division of Preventative Medicine at the University of Alberta's Department of Medicine in 2014. He was appointed as Division Director for Preventive Medicine in 2016 and promoted to full professor in 2019, and is the director of the foundation course in occupational medicine. Thank you very much for coming, Sebastian. Over to you.
Thank you very much, Neil, for those kind words of introduction. And Greg, would I be able to check with you that my slides are showing okay?
Looks great.
Thank you very much. So I would like to speak to you about developing cultures of integrity and some reflections and practical strategies in that regard. And as my predecessors have said, these are relatively short talks. So what I'll attempt to do is to stimulate your thinking, perhaps, and introduce some concepts. And I'd be delighted to explore it in more detail if you wish during the question and answer session that will follow. I'd like to speak about the proper conduct of research, as well as academic misconduct, and then sort of bring it together by thinking about a culture of integrity. Now, the proper conduct of research perhaps is the easier of these two issues, proper conduct and misconduct, because much can be achieved by thinking about and finding and then applying the appropriate rules and guidelines. And if you work at an academic institution, there likely are guidelines in place that govern proper conduct of research and that are worth getting to know and implementing. Also, the International Association for the Study of Pain has put out some guidance documents, both for research in animals and research in humans. And I've included the links here for those of you who are engaged in this sort of research. It might be worth having a look at those documents. I'll take the one about research in humans just to sort of give you a broad idea what it talks about. And it addresses issues around reviewing and approving the research by independent committee and talks about what that committee should be comprised of. It addresses the consent and the participation of subjects in research, and that they need to be informed about the goals, the procedures, and the risks of the research. It specifies that people who are participating in research must be able to terminate their participation at any stage of the research without any sort of penalty, that people who are exposed to experimental pain stimuli should have a way to escape or terminate the painful stimulus, and that people who are engaged in research on painful conditions are allocated to a placebo or sham group need to have access to alternative pain treatment. So quite useful, and there's more on the documents than I just very briefly summarized, for quite useful for people conducting pain research, and well worth a look if you haven't yet come across those. Misconduct is perhaps the more challenging topic, and it's an area where one benefits, in my experience, greatly also from having rules and procedures. I'll maybe illustrate that a little bit when thinking about plagiarism, which is something that I've come across on a number of occasions now in my work as a researcher and also as a leader of a group of physicians in the Division of Preventive Medicine at the University of Alberta. And I've always found dealing with plagiarism unpleasant, and I don't like to confront people about it. It's an uncomfortable situation that, if I reflect on the instances where I have been involved in these discussions, has been easier to have if there were rules and procedures in place that could be followed. So had to deal with plagiarism in learners and in students, and that was actually, I think, greatly aided by having a process in place at the university, and that was transparent. Everyone knew what the process was, and we followed it, and it removed some of the ambiguity around what that can result in discussions about plagiarism. What is plagiarism? What constitutes plagiarism? What is still okay? What is questionable practice? What is clearly outright plagiarism? So having some rules around that is helpful. I've come across plagiarism in other contexts as well, and on two occasions, perhaps I'm lucky or unlucky in that regard, I've been asked to peer review papers that had copied text from my previous papers without attribution. And in one case that was just a couple of lines, but the phrase was unusual enough, the phrase that they put in the paper, that it sort of reminded me that I actually had written that form of wording, and I was able to recall where that was, and it provided the role of being as a peer reviewer provided a nice avenue for communicating that, because the journal is asking for your opinion, and they even send you a form that you fill out by way of clicking on a link, and then you can elaborate the concern. And again, I thought that was relatively useful to have that clear pathway of communicating what the concern was. It happened again on an unrelated paper where over a page of text was sort of taken from my previous writing, that and again without attribution. And I was perhaps a bit more harsh in my comments back to the journal editor about how that was not okay. So if I can share any reflection about this sort of thing and dealing with plagiarism, it would be that I found it comforting, for want of a better expression, to have a structure in how to deal with it, and have a transparent process, and therefore have a clear set of steps to take. And if you're working in an academic institution, perhaps in a leadership role, I think it would be prudent to find out whether your institution has policies in that regard, and likely the answer is yes, and to apply them in case there is this concern of plagiarism raised or outright plagiarism, because of course there is a chance that one's action in this regard will be challenged, as the outcome of such investigations can be quite consequential for the individuals concerned, and then having a set of guidance documents and procedures is helpful. Fabrication of data is something I've also come across, and this links back to the previous talks that you've heard in this webinar about made-up trials being published. So this was my first systematic review. I'm a convert to evidence-based medicine, having previously done benchtop wet lab research, and I was quite proud of my first systematic review, which was modestly, I think, impactful, having been cited about 200 times or so now, and I was delighted that it was published, and I thought it's a great paper, and that feeling persisted for some time until it was brought to our attention that we had included studies by Scott Rubin. So that's a name that you might recall from a few minutes ago. And those studies were based on made-up data. So we now have this systematic review, and it includes data that are not true. We didn't know it at the time, but we now know it. So what do we do? Trying to turn these lemons into something resembling lemonade, we looked at it again, and we got together with some other people who had been similarly affected by including those reports by Dr. Rubin in systematic reviews. And we looked at, well, has it actually made an impact, and what has the impact been? And quite interestingly, it was only one of 6 quantitative reviews, including those Rubin reports, that would have reached different conclusions without those data that ultimately turned out to be made up and fraudulent. And it never really made a difference to the conclusions if the number of patients from the Rubin papers was less than 30% of patients included in the analysis. So that actually systematic reviews conducted to modern standards seem to be, to some extent, robust in terms of being only affected if it's really a substantial number of patients that were from these fraudulent reports. So I thought that was an interesting finding, and it certainly brought the issue of fabricated data and research integrity onto my radar screen as something that I'm now looking out for. And I think it's great that this topic gains more traction in the research community and the pain community especially. Now, what do we do with this? How do we build? How do we develop a culture of integrity? And I'm not sure there's a single answer to that. So I was looking for articles and resources that might help one build a culture of integrity. And I came across this article, which is written from a business perspective. So it's a bit of a different setting than the clinical or academic settings in which most of the webinar participants would likely work. But it's fairly well written, and it's actually a short read. So I would recommend you look at it. And again, I've put the link here on the slide. It makes some points that I think are very useful and that can be translated also to an academic setting, including leading by example and not only preaching but also practicing the culture of research integrity, making your ethics code your own, as the author Robert Chestnut puts it, not just copying and pasting a policy from another institution that may or may not actually relate to your specific setting, to talk about research integrity and a culture of integrity and a code of ethics. Ideally, when you onboard people, an orientation session would be very useful as a venue for bringing that up. To make sure that people know how to report violations and breaches of ethics or integrity. And I think that's a very crucial point, to not only know it in an abstract way, but what does one actually do? Is there a particular form to fill out? Is there a person who should be contacted? What is the procedure that ought to be followed? And to demonstrate the consequences, because people will watch how you handle these situations, and they will draw lessons from how what the consequences are and how they are enforced. And I'll loop back to what I said earlier about following procedure, which is I think very useful to demonstrate in a transparent way what's going on, and have accountability as to what the steps are that one takes when dealing with breaches of integrity or ethics. So those are the points that I wanted to make. As I said, they're a snapshot of what one could explore had one more time to do so. And I'll be very glad to take any questions or comment in the discussion section that's to follow. Thank you very much for your attention.
Thanks very much, Sebastian. So we've heard a lot of talks there. It's been a bit of a whistle-stop tour of lots of different areas. And actually, we're running slightly ahead of time, which gives us a bit of breathing space. We have been encouraging people to use the Q&A box. We do have a couple of questions in there. We're going to move to a discussion now facilitated by Professor Amanda Williams. She's a professor of clinical health psychology at University College London and a consultant clinical psychologist at the Pain Management Centre, University College London Hospital, UK. She's also section editor for psychology for the journal Pain and consults on research to the International Centre for Health and Human Rights. Her research in pain covers evidence for psychological interventions, evolutionary perspectives, behavioural expression and its interpretation, pain from torture, and wearable technology for people with chronic pain in their own environments. She's written over 300 papers and chapters on pain and psychology. So over to you, Amanda. Thank you very much. If the other panel members can put their cameras on and mics on, that'd be great too.
Thank you very much. Terrific presentations. So I hope people have enjoyed those. We've got a question which I think all of you might like to answer, which is, after thanking you for your presentations, given the suspected and proven levels of spin and fabrication in peer-reviewed publications, is the current model of peer review fit for purpose? And if not, what are the ways forward? Quite a tough one.
It is. Anyone want to jump in first on that?
I'm going to let you go first, Neil. And I'm kind of interested in Amanda's opinion on that as well.
Well, as am I. I mean, I think in a way, if you ask a question about peer review, it's odd to ask it without asking a question about our current model of publishing, full stop. So it's difficult to see a way of changing peer review without radically changing the current model of publishing. And for more reasons than research integrity, there are plenty of voices calling for that and a sort of decorporatization of the research publishing process. I've often thought peer review might be our least worst way of doing it, but it seems to me that as an editor, that the system is under enormous pressure. Academics no longer have the kind of space and time to breathe. It is essentially unpaid work for a private industry that reaps enormous profits off the back of that skill and expertise that it doesn't pay for. And I suspect the process of cramming it into the gaps in our lives means that often it lacks the detail and level of scrutiny that it requires. Also, I think there's a range of skills that are required to analyze a lot of papers, and most of us as individual peer reviewers have some of those skills, but not necessarily all of the skills, say, for instance, to look forensically at some of the data. But I do think as a reviewer and an editor, we've probably all seen examples, more frequently than we would want, where peer review was almost non-existent or fell well short of what we might consider to be reasonable scientific scrutiny. So I do think the model needs to be looked at, but I don't necessarily have easy solutions. Of course, there's other options like post-publication peer review, PubPeer, and these sorts of platforms, but it's a really difficult one, and I'll stop there.
Yeah, maybe just adding on to that, the question to me is what's the alternative? Clearly, not having peer review is a lot worse, and I am much happier taking data that have been through peer review than basing any conclusions, be they academic or clinical, on data that haven't been peer reviewed. So much so that I would, even if one writes to an author and asks for more data, then I always have a slight hesitation with that, or I pause before I ask my team to do that if we come across a scenario like that, because whatever data we get by that mechanism would not have gone through peer review. And if it's extensive, it may make a difference. And likewise, if people ask me for reports on my research, which sometimes happens, I'm much happier to share with them a published paper, because that's been through independent peer review, and I view that as validation, than sharing something that is sort of pre-publication. And I suppose I have a really easy answer of how to at least maximize the benefit one might obtain from peer review, and that is to make it count for people. So at my institution, I have the dubious pleasure of going over annual reports from faculty members in my division, and there's a section where people can note what they've done in terms of peer review, and they can describe what they've done, and it matters in terms of assessing their merit for that year. Doesn't count as highly if you do a lot of peer review than if you publish a lot of papers yourself, but nonetheless, it does count, and it's viewed as an integral part of the academic work, and it is actual work that we encourage people to do as part of their working time, and not as part of their spare time. Neil, as you've kind of alluded, you do it in 5 minutes here or there. So if you value it as an important contribution to the process by which research is generated and published, and if you have a section on the annual report where you can note it down, and you know that when your merit increment, it's a North American concept, but people listening from the United States or Canada will know what I'm talking about, at least if they're in an academic setting. If the merit increment, at least to some extent, is also impacted by that sort of academic work, I think we give it its proper place. It's more challenging perhaps for someone who has no academic portfolio and truly does it as a labor of love, because that may mean they're doing it in addition to a job rather than as part of their job. So that's how I would view it.
Yeah, I think I agree with what both Neil and Sebastian have said. I think that it takes up an awful lot of time, and the requests that we get through are numerous. I mean, I've been on maternity leave over the last few months, and I'm still getting up to 10 requests a week. And I'm simply saying no, but there is a guilt that you feel because you should be reviewing literature. But Sebastian, I like your suggestion, but in my university, you get no credit for doing that work. And it's barely on your CV either. It's not accounted in people's workload, and we do it for free out of the goodness of our hearts. And I think that that's a very strange thing to do. I think we do a lot of things for free in academia that shouldn't necessarily be done for free. And I think, linking back to the talks, I think that some of the issues that you have just seeing one paper and only being able to review one manuscript at a time is that you miss some of the untrustworthy science, because the only reason why we started investigating Montacone was because it was 3 articles that we found in the review that Amanda led that seemed to be outside of the norm. But without having that systematic review to group together all of those trials, we would never have suspected that if we were just reviewing one article. So I think that is another issue that I don't know how to get around. I actually don't have any answers, but I think that it needs to be valued more, is what I would say, either through recognition or money or another way. There has to be some better incentive, especially for younger researchers, to peer review.
Amanda, can we take your view on it?
Yes, I was hoping to hop in. I very much agree with all 3 of you. And yes, we do need to overhaul the whole system. And I gather Neuroimage has recently done that. All the editors resigned and said to Elsevier they were no longer going to buy into the system. So interesting, first of several perhaps. But I really like what Sebastian was saying about it being formally recognized, because I think there are a lot of skills that are really useful to refine. So in younger researchers, they're skills that they can be helped to develop, and older researchers have a great deal to offer in review, and that seems to be much better than suggestions of either naming or paying or both. But the other point I wanted to make was that when we spotted these Montecone trials in the review, I was curious about this guy because I've gone to lots of pain conferences and I'd never never been aware of seeing him or hearing him or reading a poster by him. Of course, my memory isn't perfect. And so I talked to a few colleagues who have been as long in the field as I have. And one of them said, oh, yes, I remember reviewing one of those papers. And it was actually one that was in our review. And he said, and I just didn't believe it. I said so to the editor. I said very strongly, this is too good to be true. And, you know, I think you need to be really careful. And the editor completely ignored it and went ahead and published. So it isn't just, so even when peer reviewers have good antennae for these things, it's also, there's a bigger system that there's so much pressure to publish findings that look newsworthy or special or extra good, and to hype them, as Emma was saying in her talk. And that just doesn't seem to me to be very compatible with academic values of trustworthiness and reliability.
So some of this seems to speak to this problem of commercializing what we hope is a kind of collective effort for good, which science is supposed to be. I mean, the other sort of dark side I think worth throwing in here is the rise of the predatory journal that will give you the illusion of peer review for a fee. And this is definitely happening. And as we found in Michael's fantastic review of retractions, fraudulent peer review is now a thing. There are scientists setting up peer review rings amongst their colleagues. And there was one example, it's humorous, but just to illustrate the point of someone who had more than one retraction, and they had nominated their wife to be the peer reviewer of their articles. So, you know, it's so there's fake peer review, there's illusory peer review, there's bad peer review, and then there's good old-fashioned, solid, reliable peer review. But what are we getting and when is difficult, isn't it?
Yeah, and I'd say as a section editor for pain, reviews vary enormously. The reviewers on the screen with me, I rely on heavily and trust completely, but that isn't so. And it's quite a lot of work reading through reviews and getting a sense of how thoroughly people read the paper, whether they went back to a protocol, if it was a trial, you know, how much they checked through consult statements and all the rest. Yeah, it doesn't feel like a sustainable model with the number of journals and the amount of publication at the moment. And yet it quite possibly is the least worst, and we could get something worse. Greg wanted to ask a question, please.
Thanks, Amanda. I'll pop on camera for a second. Thank you guys so much for wonderful presentations. And the question I had, I feel has been touched upon now a bit tangentially by Neil as well as Amanda. And, you know, we're hearing talks about spin and bias and fabrication within the literature. And what I'm curious, and I understand that this is conjecture as well, and there isn't data to back this up, but I'm curious to hear from the panelists what you think is the number one factor, or rather number one, perhaps a way to phrase it, external pressure that's leading folks to introduce bias to their research, to perhaps fabricate. Neil, you kind of spoke toward this new climate of trying to take on as much as you possibly can, or as Amanda touched upon, the pressures of, you know, having that, you know, newsworthy finding. Again, just to name a few, I was curious if you could just provide your thoughts as to what you think is transpiring, perhaps upstream of data analysis and reporting that might be leading to some of these factors affecting the literature.
Wow, that's a complicated one too, but it's a great question, Greg. Anyone want to go first?
I can go first. I think from my perspective, it's a job. It's either keeping your job or being promoted within your job. And so, you are promoted based on how many publications you've done, how many times you're cited. Better results resulted more citations. And that's very much part of the academic promotion model. I know in North America, you need to get tenure and you have to reach certain benchmarks in order to do that. And so I think that job security is not always the best in academia, and so making your results sexier and better and more significant is definitely going to help with that. And then grants, you're not going to get the next grant if everything that you found is null, unfortunately. I'd like to think differently, but you need to have results to get the next grant. So and that again feeds into promotion, keeping your job, moving jobs, getting a higher salary. So I feel like I'm quite cynical with it, but I do think that, and I don't have a suggestion yet as to how to do this better or anything, but there's a lot of soft contracts in academia and not a lot of job security.
Oh, they're great points. I mean, and I think, but it's not just about extreme results. I mean, we spot some trials that we don't trust on the basis of their extreme results, but what about the ones with quite standard results? Actually, publishing in volume, you can build a career that way, whether the results are extreme or not. There might be a good strategy in publishing results that are utterly unremarkable, and as long as the methods look good, whether the trials happened or not. I think there's a really fascinating body of work that is probably impossible to do, looking qualitatively at people who we know have committed research misconduct and trying to debrief them about what drove them. And I'm not aware that that's been done, and you can imagine how hard that would be to do. But really, if you think about academia, we chase careers, but we're also encouraged to chase gongs and recognition and all sorts of prestige. And we shouldn't ever rule out good old-fashioned narcissism either. That I think that's a big driver in some academic circles and could potentially be a contributor, as well as all those other career pressures.
I think the issue is perhaps less black and white as one would hope. And anyone in an academic setting, especially in North America, will have come across the phrase of unconscious bias in recent years, and probably also had to do some unconscious bias training at one point or another. And I think there is outright fabrication, and I'm not sure what how to spot that in advance, because it takes a particular mindset to engage in that and try to have some sort of advancement, be it career-wise or financial, from that from fraud and from outright fraud. But there's also the researcher who absolutely believes in an idea and is perhaps not even consciously less likely to question a result that is in favor of the idea than to question a result that goes against the idea. And we had much of this discussion around clinical research and science done with human subjects. But if you broaden the scope a bit and you go sort of into work with experimental animals or even cell lines, well, there's less accountability of all the experiments on cell lines you discarded because you thought there was something wrong with this setup, it didn't quite work out, and you just needed to tweak it a little bit and try again the next day. And then if it works, great, you might want to take that result and you run with it. So I think there's a role also for being misled perhaps by an idea in which one believes with too much conviction. And I think if one can have an unbiased frame of mind about the subject which one investigates, that would be an advantage. Of course, it's hard to do. If it's a subject matter you care about, you are likely to have some sort of opinion, and you're likely to investigate something that you truly believe is meaningful and impactful, and you might even have an idea of whether the method or procedure or therapeutic under investigation has an effect or not. What I find noteworthy about the trials that and studies that come in the fullness of time to be viewed as false or fraudulent or fabricated is that they're not single author studies. There are multiple co-authors on those studies, and you got to question what has their role been. Has it been that they all colluded in the fraudulent activity, or has it been that they were just too trusting? They were flattered to have their name included for some edits to the manuscript without looking at the primary data, or without looking at the primary data with sufficient detail. And I think there is perhaps something that one could do or could use as an angle to improve the system by demanding scrutiny also of the co-authors and having perhaps less of a culture of just thinking it's going to be okay, I'm not going to check that, and I'm just glad to get another publication for some sort of minor comments on a manuscript without looking at the primary data. So I tend to be of the belief that everyone who contributes to a research article, not everyone does everything, and people have particular roles, but there is also a degree of shared responsibility for the results. And there's a responsibility for co-authors to engage in a discussion with the research team if something doesn't look right, and that there should be a culture where that is welcomed. And for what it's worth, when I onboard people to my research team, I make it an explicit part of their orientation to say, this is a culture where you are encouraged to bring up points of criticism. And if you think that something doesn't make sense, you're encouraged to speak up, and you're encouraged to raise questions. And if something doesn't sound right to you, you're encouraged to bring that up. And then if people do that, they get praised for it. And if they happen to be mistaken in bringing up their point of criticism, and it turns out, well, actually, what has been done is all right, but one may need to read a few papers before fully understanding why it has been done. That's not taken as a negative against them, but instead they're encouraged to come forward and keep questioning, because it's a really good way for them to learn. And if truly they find out something that isn't going right, and it doesn't have to be fraudulent, it can be an honest mistake, and there's a lot of science with honest mistakes, then it's of benefit to the project. So I think my suggestions would be to have I suppose it's a culture of integrity issue again, have a forum for this sort of open discussion, and where the other members of the team are not offended if someone brings that up, but instead welcome it, and co-authors to have a responsibility for, at least to some extent, checking that what's going on is okay. In those cases where research papers are retracted and there's sort of a string of fraudulent papers, the co-authors on those papers are also going to get some questions, and it may not be that they go to prison like the main perpetrators of the fraud, but it's going to be uncomfortable questions if you get to be in that situation, I would imagine. So for others within the team, even if they're more junior than the principal driver of the project, to feel free to question it, and for such questioning to be encouraged, I think is a way to guard against mistakes or worse in terms of research being published that isn't actually true.
Great. I'm a bit mindful of the time, but Amanda, I would love to hear you just come in on this question.
I don't think I have anything to add to that, but I just wanted to say there was a question which Emma has answered online, but I think if we could do a quick airing with Emma's answer. And it was a clinician who is setting up a journal club and wanted to know how to evaluate what's a trustworthy paper. And I'd be fascinated to know Emma's answer, and I'm sure some of our audience would.
You're muted, Emma.
Sorry, I was typing. I didn't want to interrupt Sebastian. Just briefly, I think time and time again, and Andrew Moore has spearheaded a lot of this work, but we know that the Cochrane reviews that have evaluated from PAPAS are extremely high quality and trustworthy. And please accuse me of bias because I'm an editor and I've written a few of them. But the methods and the quality checks that those PAPAS reviews have been through are extremely high. So in terms of trustworthy evidence, I'd certainly start there. And then my second point in the chat was to be critical of the literature. If something looks too good to be true, then it probably is. And there are other tools available. You know, you can look at reporting guidelines and check it off against Amstar or Consort. And just, I encourage you to be critical, but not cynical.
Just to add before we finish, if you have a range of different designs that you want to include in your journal club, then the CASP UK website have critical appraisal tools that will guide novice research users through important questions to ask for those papers, and they're free, so I would point you in that direction. We are up against, and we've gone a little bit over the clock. Thank you, Amanda, for leading that discussion. I just want to finish by thanking our speakers. Thanks everyone for your great talks and your contributions to the discussion. To thank Greg for his support from IASP, it's been great and we really appreciate it. To thank all of you for taking the time out to come and join our webinar, which I hope you'll agree is a topic worth reflecting on and thinking about a little bit more. There is a link to a survey. We're very much interested in your feedback about the webinar. We're looking to do many more of these over the coming years for the SIG, and we would love to know ways in which you think we're doing well and that we could do better. And just to finish with the pitch and the plug that I started with, we threw the webinar open to all IASP members. But if this is an area of work that interests you, that triggers a bit of passion in you about quality and rigor and methods, we would love for you to join our special interest group and join us for future events. So with that, thanks everyone, and good night or afternoon.
Yeah, I might add a word or two really quickly, Neil. Thank you guys so much. You know, as you've rightly stated, we've come to the conclusion of our webinar, Quality, Bias, and Integrity in Pain Research, Creating the Next Generation of Pain Science. IASP and myself certainly want to thank Andrew, Emma, Michael, Neil, and Sebastian for presenting, as well as Amanda for providing her thoughts and for facilitating. As a reminder, the recording of today's webinar will soon be available on IASP's Pain Education Resource Center, and we encourage all of our IASP members to explore the other offerings available there. We'll be back here next Thursday, April 27th at 2 p.m. Eastern US time for our next webinar, being produced by IASP's Social Aspects of Pain Special Interest Group, and it's titled Demographic and Sociological Approaches to Population Pain, Trends, Disparities, and the Role of Upstream Factors. Thank you all so much and have a wonderful, wonderful day or evening wherever you find yourself. Take care.